Hello, everyone, and welcome to today's webinar, A Military Culture Approach to Screening, Brief Intervention, and Referral to Treatment, or SBIRT, for Veterans and Active Duty Personnel. I'm Tracy McPherson. I'm a Senior Research Scientist at NORC at the University of Chicago. You are welcome to contact me at any point following the webinar if you're interested in more information about what you hear today or about screening and brief intervention, or if you're interested in learning about our other activities, including our other training webinar activities and technical assistance activities that we're able to offer you through the National SBIRT ATTC. I want to take a few minutes just to outline the importance of this webinar and, in fact, the entire webinar series that we're able to bring you in 2015 and how it's important to health professionals at this time. As you might know, the passage of the Affordable Care Act in 2010 avails several opportunities for service delivery and payment reform in healthcare, including recognition of the importance of screening and brief intervention for substance use disorders to reduce disease, disability, and premature mortality. Specifically, the Essential Health Benefits, or EHB, provisions of the Affordable Care Act carved room for SBIRT to have widespread adoption. The essential health benefits are a set of healthcare service categories that must be covered by all insurance policies participating in state health insurance exchanges and all state Medicaid plans beginning in 2014. The Affordable Care Act stipulates that this EHB package must include mental health and substance use disorder services at parity with other medical and surgical care, prevention services, and rehabilitative services. An anticipated effect of these new standards is that the pervasive treatment gap between individuals who have substance use disorders but do not receive treatment may be reduced by expanding substance use disorder care services in primary care services, particularly in medically underserved and low-income populations. To accomplish this, medical and other staff will need to become suitably trained in screening, brief intervention, referral to treatment for substance use disorders, and adopt and use validated screening tools that are standardized to electronic health records. This webinar series is one component of a national effort to educate the workforce about screening, brief intervention, and referral to treatment, and to expand its use. As you can see, we have quite a lineup in 2015. We're almost just about halfway through our series, so you have the opportunity to take advantage of our upcoming webinars coming up in July and August, as well as take advantage of all the webinars we've done so far. We've made all of these available to you at no cost. They're archived at the hospital.rev.com website. You can not only access the recordings, you can download PowerPoint, CDs. We really encourage you to share this with your colleagues and with your staff and take advantage of the full range of topics we're able to offer you. Of course, all of the webinars in this series are produced in partnership with NORC at the University of Chicago, the Brief Intervention Group, or the BIG Initiative, our strategic SBIRT partner, the National Screening, Brief Intervention, or Referral to Treatment, ATTC, NADAC, the Association for Addiction Professionals, and SAMHSA. Materials for your webinar today are available at this URL. You can access all of the materials for this and any webinar if you go to the hospital.sbirt.web and you go to the webinar tab, and you'll be able to access the CE quiz, the PowerPoint, everything we'll be referencing today, you'll be able to access. And you'll also receive a follow-up email that will include information on how to access these things as well. You'll be able to ask questions throughout the webinar through using your questions pane. We'll take questions at the end. We'll try to get to as many of those as possible. But as you're thinking of them, go ahead and get them into the queue, and we will do our best to address as many as we can. If there's some we don't get to, and there's some things that we can provide for you later on and post those to the website, we will certainly try to do that. So go ahead and get them in early, because oftentimes we do have quite a few questions, and we're not able to get to all of them, but we will do our best. Our technical facilitator today is Misuse Story, and she's in professional development at NADAC. And any questions you have about technical concerns, issues, strategies, she'll be able to address those. You can use the questions pane for those issues as well, and she'll be behind the scenes trying to help you navigate those. It's my pleasure to be able to have three terrific presenters today. Our first presenter is Dr. Tanya Frazee, and she served as a hospital corpsman before. After a service-connected disability resulted in her retirement from the Navy, she completed a bachelor's degree in public health and a master's and doctoral degree in nursing. Dr. Frazee teaches in the Department of Community, Systems, and Mental Health Nursing at Rush University. She's the Nursing Education Manager for Interprofessional Continuing Education and the Educational Coordinator for the Road Home program at Rush. Her areas of expertise include veterans and their families, mental health, individuals with disabilities, and people who identify as LGBTQ. Our second presenter today is Mr. Nicholas Turner. He was Arts and Social Work from the University of Chicago School of Social Service Administration. He's worked in various mental health and substance abuse settings with children, adolescents, and adults. In addition to his work with the Road Home program, Mr. Turner is an adjunct faculty member at the University of Chicago. He's also co-authored the book Mindfulness-Based Sobriety, Addiction Recovery, that was published by the New Harvey in January of 2014. Mr. Turner is a licensed clinical certified and a member for contextual behavioral science and national interviewing network of trainers. And our third presenter today is Dr. Niranjan Karnik. Dr. Karnik is an associate professor in the Child and Adolescent Psychiatry section, the Department of Psychiatry at Rush Medical College, and an adjunct faculty in the Department of Community, Systems, and Mental Health Nursing at Rush College of Nursing. At Rush University, he is also the medical director of the Road Home program, Center for Veterans and Their Families, and director of the Rush University Life Course SBIRT training program. He concurrently serves as an associate faculty member of the McLean Center for Clinical Medical Ethics at the University of Chicago. His research focuses on community-based interventions for high-risk populations with psychiatric and substance use disorders. Pleasure to turn the presentation over today to Dr. Frazee to begin talking to you about a lot of the really great work that they've been doing at the Road Home program.
Thank you very much, Misty. So just to give a brief overview to everyone, I am actually going to present sort of a taste of military culture, because I think in using SBIRT, understanding the population really makes a difference. Then we will be talking about substance abuse and the military population in general, give you a brief introduction for those of you that aren't familiar with SBIRT, review the process, and then go over a couple of case studies together, which will obviously lead to the questions and answer portion of the presentation. Military culture is very unique. We're different than everyone else. Military people have a unique set of pressures that are put on themselves and their family members. Particularly the family members and what they experience feeds back into the ability of the military member to function when they're on active duty, and then also what happens after they actually leave the service. For most people, healthcare providers might be a little bit different, but most civilians, your job is actually what you do. In the military and several other professions, it defines you. It's absolutely who you are. It's with you 24/7, 365 days of the year. In the military community, there are extremely clearly defined rules and expectations, not unlike standard operating procedures or legislative restrictions that exist in other communities. But again, because you act a contract that says the United States government and the citizens of the United States basically own you, you're bound to, and that does affect the rest of your life. It's very interesting to note that despite the fact that different branches are all underneath the same structure, there are distinct values, and that's something important to pay attention to within the community. So after you have identified that someone is a veteran, it's important to know which branch of the service that they belong to. You'll see some of the different slogans and core values. The Army primarily, it is one of the largest, second largest force. They're on the ground, boots on the ground, doing their thing. They actually long periods of time. The Navy tends to be more transient. Obviously, there are aircraft carriers, there are submarines, there actually is an air component as well, but they don't tend to be embedded in a place as long as the Army is. Then the Air Force, they're extremely mobile. They can go wherever they want, whenever they want. Marines, first forces on the ground. I'm sure everyone is familiar with some of the considerations and some of the great exemplified by members of the Marine Corps. However, it's understand that they work in conjunction with and actually under the blanket of the United States Navy. So there's a very, very strong connection between Marines in terms of the healthcare component. Navy corpsman, who is the main person, cares for a lot of their family members related to everything, both physical and mental health. The Coast Guard is extremely specialized, and they should be, as all other branches are, but to a very high level. After 9/11, the Coast Guard was put under the Department of Homeland Security. So they actually have to answer to the Department of Defense as well as Homeland Security, and they actually have. Another important thing to consider when understanding where a military person or the family member comes from is whether that individual and the family is under the active duty or unit. As you can see on the right and left-hand side of the screen, they actually have some very different aspects. Again, like I mentioned, the active duty, 24/7, 365. They live on or near a military base. Most of their medical care is through the military. They live and deploy as a unit. So they have a very close social structure with a very defined set of individuals. Every few years, they will change their duty station or PCS. It only tends to be very deeply entrenched in military culture. An important aspect of that is actually the families will sometimes have a surrogate mother or father or partner, depending on the individual that's deployed. The children tend to find other adults in the community that become a surrogate parent. The children get very attached to that parent, so that's something to consider in terms of moving forward with a family unit, is the sort of untraditional family or the family extended out of what you would expect. Reservists actually may be more at risk for difficult mental health situations because they have to hop back and forth between the military world and the world of the civilians. And I apologize. Let me move. Misty, I need to move forward. And it's not. Okay. I apologize very quickly. So culture also relates to lifestyle and language. If you speak Spanish, if you speak English, if you speak Japanese, it makes a difference. Military people speak a very unique language. It's very regimented. There's a lot of acronyms. You get up, you have Reveille, you have PT. Is your idea probably of joining a gym. You shower. You have a UOD, which is your A, and that's based on your military operations specialty. Basically, long story short, military people might not have to make quite as many choices as you think they do. So when they come back into the civilian world, that becomes another potential area for difficulty. I had to choose what I ate, what I wore, make decisions based on my particular job. So when you're out in the world faced with so many different possibilities. It's probably very obvious to all of you that the service does expose people to stresses and hazards that have no civilian equivalent. And it's very difficult. There is no set system that to the civilian life. There are many programs that exist, and a lot of them are very good. However, it's very difficult to go back once you've been into boot camp. And traumatizing experiences in the military include injury to self or others, the threat of death. The most common would be an IED blast, the death of others, friends, colleagues, people around you. Human suffering, very common, unfortunately, particularly in veterans of Yugoslavia, was having difficulties in disseminating, seeing and handling mutilated bodies, killing others, obviously, and then military, which is still a problem, and it occurs in both men and women. As a result of being exposed to those types of situations, polytrauma can occur from IED. It's estimated that over 30% of individuals, which includes situations like multiple traumatic brain injury and mental health issues. Moral injury, also related to spouses and families and partners of individuals that have served. In this global world that we have, which we're now sharing a webinar, it's very easy to understand and be connected to people. And difficulty if I happen to see you when I'm Skyping and then something happens and we can't connect, problems ensue. Hazardous exposures to multiple materials, chronic pain, and traumatic brain injury. Post-traumatic stress disorder remains a huge issue, and unfortunately in females, like sexual trauma, and the commiserate risk for self-harm and suicide and substance use disorders. Now I'm actually going to turn the presentation over to Dr. Karnick.
Thanks, Tanya. So I'm going to take a question around substance use and substance use disorders. As you've seen, is an interesting and complex culture, as Tanya just said. The ways in which substance use becomes a part of that culture, we think are important to understand as a context for launching any type of SBIRT intervention or program. Here we go. So, although knows that illicit drug use is lower amongst military civilian populations, there are pockets of heavy alcohol, tobacco, and prescription drug abuse. The thing is, the prolonged nature of the combat that the U.S. is in has resulted in what we think is a higher and rising nature of this use. we see our populations in our program here are highly stressed when they come back from combat, and even during combat are using some of these substances. Those with combat exposure and multiple deployments, therefore, are at even greater risk. There seems to be a certain proportionality to that, out in the literature as well as in our sort of individual experience. Cumulatively, deployment duration and frequency are associated with higher rates of heavy alcohol use among active duty service members. And then unhealthy drinking rates and alcohol-related consequences are also correlated with the intensity of combat exposure, specifically among Reserve and National Guard personnel and younger service members. So as Tanya was outlining, you can see that there are sort of certain subgroups within the military that are actually at disproportionate risk. And these would be the individuals who either have a more intermittent connection to the military, like the Reserve and National Guard, or perhaps are just more novice to the military, are these younger service members. And I think, people on the call can easily understand why those things would happen. So one of the risk factors is multiple deployments. And the literature shows us that these people who've been through multiple deployments are more apt to heavy weekly drinking and binge drinking. They're more likely to suffer from alcohol and other drug-related problems. They are, have sort of greater use and prescribed use of behavioral health medications, and one has to consider potential, interactions between medications and alcohol. And they're more likely to start or relapse to smoking during these multiple deployments. Alcohol use is higher among men and women in military service than among civilian populations. 47% of active duty service members reported binge drinking in 2008. Also in that 2008 study, about 20% of military personnel reported binge drinking every week in the past month. Those with higher reported rates are among those with combat exposure. Tobacco use. Similarly, during that same time period, 30% of all service members were current cigarette smokers. And one has to think about civilian rates have been dropping around smoking for some time now. And those rates are higher among those with combat experience in the military. And we see that the military is a situation where this behavior continues, even though it's changed dramatically in civilian populations. During deployment, service members report smoking helps cope with stress, boredom, and sleep problems. They also endorse the belief that the dangers of smoking are insignificant compared to those of combat, and they perceive smoking as a socially acceptable thing within military culture. So I think for individuals to understand the nature of sort of military experience, they need to understand that there's work to be done when individuals are in the military, but there's a lot of downtime, and they are removed from their families. They're in remote areas. There's very little to do. This concept of boredom is a very important factor in terms of both tobacco use, but also substance use more generally. We see significant prescription misuse. I think over the past decade, this has become a real focus of attention in the U.S., and consequently in the military, researchers have started looking at this. Abuse of prescription drugs is higher among service members than among civilians, and as of 2013 was on the rise. In 2008, 11% of service members reported misusing prescription drugs, which was up 2% from 2002 and up 4% in 2005. So you can see this steady increase. Opioid medications were among the most abused. And again, this I think has another correlation with the civilian population, but seems to be amplified in the military. In one study, 1 in 4 from Iraq and Afghanistan reported symptoms of mental or cognitive disorder. 1 in 6 reported symptoms of post-traumatic stress disorder. Disorders such as PTSD are strongly associated with substance use, and we see that almost at home program. Younger veterans are significantly at risk, as I mentioned earlier. According to a report, the 2004-2006, a quarter of 18 to 25-year-old veterans met criteria for the past year substance use disorder. And that's 5 times the rate of veterans over age 55. And finally, I'm going to cover one last piece. talking about suicidality and substance use. As most of the people on this call are probably aware, suicide rates are significantly associated with substance use. Suicide rates in the U.S. Army began to increase in 2004 and had surpassed the civilian rate by 2008. In 2010, report from the Army Suicide Prevention Task Force found that nearly 30% of active duty Army suicides from the fiscal year 2005 through 2009 involved drugs or alcohol in some way. In 2009, prescription drugs were involved in almost a third of the suicides. So this has become a high priority area for the federal government. The number of suicides is of concern. This has had congressional attention, and it's clearly something that we as clinicians. Now I'm going to switch the presentation over to Nick Turner, who's going to walk us through some of the elements of SBIRT.
Okay. So part 3 is an intro to SBIRT. So we'll do a brief introduction to SBIRT, and then we'll talk about the process and what it looks like with military members and veterans. Okay, so what is SBIRT and why use it? So SBIRT stands for Screening, Brief Intervention, and Referral to Treatment. It's just an easy way of looking at it, remembering it. By screening, we're talking about universal screening for quickly assessing use and severity of alcohol, illicit drugs, prescription drug use, misuse, and abuse. Brief intervention, motivational and awareness raising intervention that gets patients at risk for substance use or already experiencing substance use issues, things to think about and consider as far as reducing or abstaining from use altogether. And then in the cases where it's really identifies that someone has a more serious problem that requires full treatment, a referral can be made to either a brief treatment program or a specialty AOD or alcohol and other drug treatment program. We'll talk about a little later when we talk about the process of SBIRT, what that looks like and some specific issues for military members and veterans. So I'm not going to read all these, but as you can see, SBIRT is highly flexible intervention. It's being used in many, including veterans hospitals, but it can be used with many populations and in many different settings. Okay, so next part, what does the SBIRT approach aim to accomplish? So identify and effectively intervene with those who are at moderate or high risk for psychosocial or healthcare problems related to substance use. So it's not just aiming at those who would be maybe referred to as dependent or experiencing things like full-blown alcoholism. It's also aiming to identify those who are at risk for issues. So you can maybe intervene early and reduce harm. Just from general numbers, in the SBIRT approach is kind of rethinking substance use as from a public health perspective. The number of dependent users is far less than at-risk and binge drinkers. And if we can intervene earlier and provide some education and some supportive counseling based around it, we can hopefully reduce the numbers and prevent people from really kind of going over into that dependent user category. Just as far as some research is concerned, it indicates that moderate risk and high risk drinkers account for the most problems. And so being able to sort of look at, okay, so how can we intervene even with those moderate drinkers and not wait until it's too late where someone's more on the kind of dependent end of the scale is important. So if we can intervene early, reduce harm and reduce cost and long-term consequences of drug and alcohol issues. So just brief, why is the SBIRT approach important? So most patients, when surveyed, 68 to 98% with alcohol abuse or dependence are not detected by physicians. Physicians are less likely to detect alcohol problems when screening tools are not used universally. Obviously, it's easy if it's not used with every case. It can, that information can slip through the cracks. Maybe someone's not familiar with substance use, so they're less likely to kind of go there with someone and they don't ask and they don't screen, and so things get overlooked. And there's been some studies as far as specific populations that are missed, especially if you don't expect someone to have alcohol problems, and those are found the most common were whites, women, and those of higher socioeconomic status. were less likely to be screened, and they were less likely to be detected for issues with substance abuse and alcohol problems. So as far as the evidence behind SBIRT, I'll briefly go over that. So as far as meta-analyses and reviews, there's been more than 34 randomized controlled trials focused mainly on at-risk and problem drinkers. And what they found was there's a significant cost savings, fewer hospitalizations and ER visits. Screening intervention cost per patient was around $177. And looking at it long-term, the cost savings per patient was $1,170. So as far as the benefit and cost ratio is 6.6 to 1. As far as some other kind of positive results they've found, since 2003, SAMHSA has supported SBIRT programs with more than 1.5 million persons screened. Outcome data confirmed that 40% reduction in harmful use of alcohol by those drinking and risky levels, and 55% reduction in negative social consequences. And outcome data also demonstrate positive benefits from reduced illicit substance use as well. So it's not just the alcohol. And just as an example, if you're a provider where no matter what type of setting you work in, if you're seeing about 40 patients per week, 4 to 8 of these patients are at risk for experiencing substance misuse related issues, so about 10 to 20%. And with brief intervention, 1 to 3 patients weekly are likely to lower their risk. It doesn't necessarily have to involve treatment. A lot of times there's this kind of misconception or myth that everyone with a substance use issue needs to go to treatment, and that's not necessarily the case. I was working with an older veteran about a month ago, and he was over the age of 65 and drinking quite a bit during the playoffs, the NBA playoffs with his friends. And recommendation for him would be just, be no more than 1 drink per day, no more than 7 drinks per week. And he was drinking a little bit more than that. And so just a brief conversation with him, he had reduced his drinking within a week. I had followed up with him with a week and 2 weeks, and he had reduced his drinking, and we talked just a brief motivational interview about what his reasons were, and it came out that his wife was concerned about his drinking, and he was experiencing some memory issues and some health issues, and was able to reduce with just a 20-minute conversation. So that's just one example. So how do I make the transition from business as usual to SBIRT? So a lot of settings kind of can have, what do we need to do to make this transition? So in looking at it briefly, the first step would be routine and universal employing things like the audit and the DAST, which we'll talk about in the next section. And really kind of shifting your focus and view of alcohol and drug use, not as this kind of dichotomous black and white view of you're either a social drinker or you're dependent, or you don't use drugs or you're dependent, to more of a continuum from people who are using in a safe manner and don't have issues all the way to the other end of the spectrum and in between, and being able to acknowledge where someone is at on that spectrum, and approaching it that, tailoring your approach and intervention to that. So which is, it's important across the board with populations, but with military personnel and veterans, especially using a patient-centered approach as opposed to first or upfront, and taking more of that motivational interviewing approach where you're eliciting the person's own ideas about change, you're evoking values and goals, and helping them kind of make the decision they want to make as far as their substance use is concerned, versus just delivering information and being overly directive and telling people to stop using, even though they might not be ready or able. Okay, and as we transition into what the process looks like, I'll spend some time, and we'll also in the next section after that, in the case examples, talking about specific issues with SBIRT with military personnel and veterans, and giving you kind of issues to consider, issues to keep in mind if you see a veteran or military member in your setting, how to make it more likely to be effective. This presentation, we're going to look at the SBIRT process and kind of dive into specifics. So clearly the step one, SBIRT, the S stands for screening. So no matter what your setting in is, being able to give a front desk can give a patient a health and wellness screening with embedded just a single question pre-screen. So using a brief yet valid questionnaire, and based on previous experiences with SBIRT screening will yield 75% negative responses, and if you do get a positive, you can then assess further. But the pre-screening for alcohol, so do you sometimes drink beer, wine, or other alcoholic beverages? If someone says yes, then it might mean further evaluation. If not, then you move on. And screening also for drinking limits, so determining the average drinks per day and average drinks per week is important because depending on gender, depending on age, drinking recommendations and guidelines are going to vary, and so being able to determine that is important. For men 65 and under, 2 per day, 14 per week is the recommended drinking guidelines. For women and anyone over the age of 65, the recommendation is 1 per day or 7 drinks per week. And so we'll look at kind of what that looks like. Also assessing for binge drinking and being able to sort of see if the patient is at low risk, then absolutely no further steps are needed. But if they are, then being able to sort of screen and assess further. And just kind of a clear guide. This is also something, either this slide or something similar to have on hand in case someone does screen positive in a brief intervention. You can pull up something like this just to demonstrate what that looks like. So, been drinking, a pattern of drinking that brings blood alcohol concentration to 0.08 grams per deciliter. 4 drinks in 2 hours for women, 5 drinks in 2 hours for men. So something just like a visual like this can be helpful to facilitate the dialogue. And also useful to clarify what one drink is. One drink means a lot to different people, and as you can see in that picture with those glasses, that could mean 1 drink to one person, but clearly that's more than 1 drink. Also having some sort of visual guide like this to demonstrate to people what it looks like can be important and part of the intervention. 5-ounce glass of wine, there's 5 glasses in 1 bottle. 12-ounce glass of beer or 1 can, and then also with spirits, it's equivalent to 14 grams of pure alcohol, so that's 1 drink. As far as pre-screening for drugs, how many times in the past year have you used an illegal drug or used a prescription medication for non-medical? If the response is none, screening is complete. Obviously, if it contains kind of suspicious clues, that's your signal to inquire further. Okay. Any positive drug pre-screen questions puts the patient at risk category, so the follow-up questions are to assess impact, whether substance use has serious enough to warrant a disorder diagnosis. So ask which drugs the patient is using, so the specifics, determine frequency and quantity of impacts. Mentioned earlier, prescription drug misuse is on the rise. These are the ones that, from an SBIRT approach, are kind of the most kind of marquee ones that stand out. And especially in veterans, opioids with post-injury use of opioids can lead to ongoing issues with misuse if they're not monitored closely. Military members and veterans report high levels of anxiolytics, such as Klonopin, and so being able to watch that as stimulants. Military culture often encourages use of caffeine at high levels, and this can lead to stimulant misuse. And also sleep aids. So use of sleep aids is very common, especially people, veterans and military members suffering from PTSD or depression. Okay, so the second step with screening, this says medical assistant, but it can be anyone kind of in the treatment team. Takes the patient to examining room or just the kind of the office if it's a counseling setting. reviews the screen. If it's positive, patient is asked to complete what's the audit screen or the DAST, which we'll talk about next. If negative, no further activity is necessary. So as far as the audit, so audit stands for Alcohol Use Disorders Identification Test. It's 10 questions. It's self-administered. You can also just as recent alcohol use, alcohol dependent symptoms, and alcohol-related problems, and it was developed by the World Health Organization. So when at the next slide, if someone scores 0 to 7, they're at low risk, may not need intervention or any type of discussion, but those are at risk who are using harmfully or dependent clearly need maybe, and it's just a conversation. So then the DAST, so the DAST is a drug screening test. It's the shortened version of the DAST 28, so this is just a DAST 10 question item. 10 items completed review again, Addiction Research Foundation, and exit problems related to drug misuse. The DAST, who are not at risk, so they're the abstainers, then up for use, harmful use. And those are the obvious, maybe need a brief intervention or referral to treatment. Screening, being able to keep in mind screening everyone, screening some, because as earlier, if you choose who you're screening, lead to people kind of falling through the cracks, which is, you know, what we want to avoid. Both alcohol and drug, including prescription drug and tobacco and prescription drug abuse. If you're just substances such as marijuana or cocaine, using validated tools like the DAST, usually not part of another health and wellness. It is usually part of another health. And when you're doing that screening, be able to try to do so in a non-judgmental, empathic way, especially the screen verbally through an interview. The person doesn't feel judged. And explore each substance. Patients use more than one, and so being able to explore the severity of each. Veteran issues specific to screening. Military members and veterans, especially active duty military, or not reported at all, wanting to avoid being put into a sick with, as earlier with the kind of in the warrior ethos, having an or a mental health issue with, clashes with those values and clashes with the image of being a veteran, so a person might underreport. And also things like alcohol use are prohibited during military deployments, and so if someone's active duty, they might fear loss of deployment or fear loss of status within the military due to disciplinary, so they may be unwilling to. Is even more important to be able to be non-judgmental, create an environment of safety, to encourage people and actually want to talk about their use if there's any. Okay, so the next part, so you know, in SBIRT is this brief intervention. Whoever that practitioner is that received screening data, they want to the results for this brief intervention. Sorry. The first step in the brief intervention is to raise this. So would it be okay if we discuss the results of your screening? This is a key aspect of motivational interviewing. It's a key aspect of the SBIRT process is asking permission to give feedback. Instead of just information, that can be kind of jarring. If you can kind of start the process by sort of saying, would it be okay? It gives the person a choice and be able to can prepare them to receive the information rather than forced on them. Feedback and process the response. So being able to say something like, you know, just tentative, screening results and notice that you're drinking or using drugs at a level that may be harmful to your health, and then be able to ask, how do you feel about your alcohol or drug use? Provide the information and then eliciting the person's own views to collaborate, engage the person's motivation level. Like, oh, I didn't realize that. Or they might be like, yeah, you know what, I've been thinking about it for a while. Or the person might say, I don't see an issue at all. So then you can tailor based on the person's response. And you can really get a good open-ended question like, how do you feel about your alcohol or drug use? Being able to sort of explore and enhance motivation to change, using ruler questions. So doing something like, would it be all right if I asked you a few more questions about your alcohol or drug use? And then following that up with, on a scale from 0 to 10, motivated are you to cut down or abstain from alcohol or drug use? And it's important if you questions, if the person responds with a number other than 0 is, why not that, why that number, which is their answer, and not a lower number. So you don't want to ask up. The person says 5, and you say, well, why a 5 and not an 8? They're going to give you reasons why they're not going to give up use or not want to reduce their use. So you don't want to ask up. You always want to ask down, because if then they're going to give you reasons why they're motivated. They're going to what's called change talk in motivational interviewing, so reasons why they would want to change. If the patient happens sometimes, you can affirm that they're willing to talk about it, so to talk about this, and then you can ask something like, if you were to reduce or abstain from your use, in what ways would your life potentially change or improve? So just the what if, rather than If possible, the next step would be to try to negotiate a change plan. So if the patient's change, what how could you go about making those changes in order to be successful? Those are open-ended questions that allow the person to explore change and identify their own reasons to. And then again, if you have some suggestions, it's good to ask them for, and then you can sort of say, would it be all right if I shared something with you? And then give them suggestions rather than just, again, telling them what to do. Not ready to talk about change, ask them what are some warning signs that you could look for that would indicate your alcohol or drug use has become problematic, just to kind of plant the seed, right? So you're not telling them they need to change or they have to. You're just exploring, what are the warning signs? What could come up that would, well, maybe I do need to abstain. And that's a way to talk to someone who may be in what's considered pre-contemplation in the stages of change. They're not thinking about it, they're not willing to, they're not able to, and that's okay. That's up to them because they're an autonomous person. But this has some room to just explore. And as far as military and veteran issues related to brief intervention, substance, as mentioned before, substance use, especially tobacco and alcohol, are part of the social culture within the military. So someone might not see it as a problem. It's what they do with their buddies. It's what they do during downtime. Substances such as cigarettes or alcohol may provide comfort or pleasure in situations that are really difficult, traumatic, or overwhelming. If someone is overseas or deployed or away from their friends and family, substances might be the one thing, or maybe cigarette smoking might be that one comfort that they still have. So there might be some strong attachment to it. They might be also using substances to mask things like PTSD or some other sort of mental health struggle. So giving up that substance, there might be a lot at stake. I drinks very heavily. It's the only way he can sleep. He's a Marine vet, and me bringing it up, trying to do SBIRT with him, his defenses went way up because that really he finds alcohol is the only thing that really is helping him sleep. So it's a slow process in mind because there are those positives that might have been entrenched in. And when doing the brief intervention, being able to sort of, if you're doing it, especially with the military, having the things Dr. Frise talked about, like the military culture in mind and military, and able to use language that they're going to identify with and And then lastly, referral to treatment. So practitioner then provides, if necessary, like if someone's in the really dependent end of the scale, they may need a referral to treatment resources they could utilize either in the moment or the future. Being able to available in your area, would it be okay if I provided you with a referral and actual consult? That's an important thing. If you can kind of do, makes it more likely for a person to follow through. And there's things like, quick access to the SAMHSA behavioral health line, the website to find treatment, and with military members, if they're using the VA, being able to explore that. But if it's outside of the VA, for civilian providers, utilize resources such as this. For the patient, if they're not ready to seek treatment, you can ask permission again. Would it be okay if I gave you some resources you could utilize in the future if you decide to make that change? Planting the seed, you're not forcing it on them, you're just giving information that they can put in their drawer. And if they decide to change in the future, great, they have that. As far as military and veteran issues related to referral to treatment, if a military member, again, if they choose to seek treatment, it begins a sequence of commander involvement, which can be perceived as career-ending if they notify that someone within the military that they have an issue. It could really kind of they would be released from duties to attend treatment, which makes confidentiality difficult. If they're gone suddenly, people are going to know and they're going to suspect. And there was kind of, in some surveys of recent veterans, so they sort of listed reasons such as they don't want to be seen as weak, they don't want to be treated differently by leadership, and also they believe they're unable to get time to engage in treatment. Or in general, if they want to go outside of the Department of Defense or the VA, they might be referred to civilian providers, which could be good, but on the other hand, a risk there is the civilian providers might not be trauma-informed, which can cause issues. Prior to my experience working with veterans and military members, I was working in a civilian substance use agency, and we had a veteran in group, and I did a guided meditation where there were mountains, and he flashback of when he was overseas, and and I was able to process with him, and we worked through it. But these are things that working with military members and veterans that might come up and catch people off guard if they're not informed. Okay, now I'm going to presentation back over to Dr. Karnick.
So the last part that we're going to launch into is just by way of introduction to this, I wanted to just tell folks a little bit about Rush because we sort of sit at a little bit of a unique nexus. The Road Home program, and if folks want to find out a little bit more about it, they can go to Road Home Program. It's one part of the .org, and I think Miss on the access point, so you can click on that if you want. So Road Home program is actually a private treatment center for veterans and their families. So we sort of sit at a different point than the Veterans Administration hospitals, which are entirely funded by the federal government and treat veterans almost exclusively. There are some programs that treat beyond that. At the Road Home program, we're able to actually treat the veterans and their family members, and hence why I, as a child, and running. But Nick and Tanya both work on the staff with me at Road Home program, and we end up doing a great deal of work with families and veterans. And in the context of substance use, you can imagine that this actually is a significant force in terms of both something we see that impacts the entire family, something that is often comorbid with post-traumatic stress. Importantly, we are part of two networks across the country. One is called Welcome Back Veterans, and the other is called, it's a relatively new one, actually, as of last week, the Warrior Care Network, which is hosted project. Are all actors that provide care to veterans. We're fortunate our center care without any financial restrictions. So we do not charge veterans or their family members that they receive here. We get to treat them independent of their financial capacity. So the cases that I'm going to present to you are sort of amalgams of cases. But before I get into the ones that I have on the slide, I have permission from a veteran from yesterday to tell you his experience with alcohol. He is a veteran who, in one of the earlier combat situations, and you know, pre 9/11, he actually in the VFW here, and he regularly goes for a regional meeting of the VFW, and he told me a story how he at one of the VFW conventions at the bar, there was a great deal of drinking and, in the evening, and you know, the hotel, I think, expected that these go to bed and, you know, wake up the next day and probably check out of the hotel. Well, he and his buddies kept partying, and they eventually ran out of alcohol. And one of these individuals decided that he, you know, restriction, because he said, I'm, you know, a Navy, you know, I'm used to getting into places and get, you know, places where people ordinarily wouldn't. On their way back to the area where the open bar had been, the door where the door in the area was locked. Seal ended up removing panels in the ceiling through a crawl space into the room alcohol was, and then from the inside. They subsequently both cases or something to drink, and then, you know, basically stayed up the rest of the night drinking per mile drunk the next morning at 7 a.m. I think the example, I mean, you know, interesting element, highlights the communal nature of alcohol and substance use within the military. You know, this is the way done together, part of the nexus. You know, maybe more so than other situations where individuals might think alcohol behavior. You know, even more so than life or you know, some of these other contexts. You know, a key social component. It is characteristics of. So I'm going to quickly move is Andy, who's a 30-year-old veteran who served in Afghanistan and Iraq. He completed duty across 2 theaters. He was 18 and soon started smoking and drinking with his fellow service members. The only times where he could go the stress of combat. So just as we're thinking, imagine yourself in this situation of, you know, far away from home, perhaps you're under constant threat of attack or fire, and you know, people hand or alcohol. That becomes a way for you to chemically relax. This is, I think, a relatively common situation and I'm trying to advance the slide, Misty. Can you move me ahead? In Iraq, he witnessed his best friend get killed with an explosive device, an IED. He also shot and killed several members of his platoon were injured and or suffered period. Andy likely has some mild TBI as a result of concussive blast. He has also been honorably discharged from the military and is trying to attend college. In this situation, you know, one of the things to be aware of is factors that are in the military and how to add in. Sorry, Miss. For some reason I can't advance. He currently has nightmares and flashbacks to his time 3 to 4 units of alcohol, himself fall asleep. This is a very common coping strategy that we see among veterans here at the Road Home program. And on the weekends, he often binge drinks greater than 5 units in 2 hours with fellow veterans. Took about 1 pack per day and is starting to experience ongoing anxiety and stress. So in approaching this kind of case, let's discuss screening as college to military. So you do if you ask in the military and you ask what was your role in the military, do you want to tell me? We find that this really helps veterans feel comfortable that you're into this. In sort of American society, oftentimes our veterans aren't sure about the reception they're going to get, and that may be characteristics in the post-Vietnam era, is that still embracing of military and support of them has been checkered at best, and they may hit even among healthcare professionals. Asking about, you are in some ways at least acknowledging them, being a safe space for them to discuss it. Ask permission, parts about the SBIRT and the motivational interviewing perspectives, permission to discuss alcohol and tobacco. I would recommend that you address, it can be difficult to alcohol and tobacco in one intervention. Substance helps prior to discussing. It's okay to acknowledge that this, it may play a very important role in you to going to sleeping with anxiety. That can often really be comfortable that you're hearing, validating their experience. Again, ask questions to address, even comorbid conditions, sleep interventions, psychotherapy for the PTSD. From our perspective, when we see, significant PTSD symptoms alongside substance use, oftentimes it is easier for us to start to work on the PTSD symptoms with them, and then we will sometimes see them start to self-decrease their substance use as their trauma symptoms get better. So it's important to weigh that, which side of this are you going to enter in on in terms of intervention. In case 2, Betty's a 25-year-old Navy officer who served in combat theaters in Iraq. She served on ships and is part of a healthcare team for the Marines. She reports that she was sexually harassed and assaulted on the ship. She never reported these events for fear of appearing weak and out of concern that her commission would be in danger. Since returning to the U.S., she started to date men and has found it difficult. Simply being close to a man will trigger flashbacks to her assault. She's concerned that she will never get better and be able to have a serious long-term relationship. She started using a combination of alcohol and cannabis to address sleep and anxiety. She smokes 3 to 4 times per day to control her anxiety. She uses alcohol when she's unable to sleep or is having flashbacks. She never drinks with other people. She estimates that she drinks 2 to 3 times per week at about 3 to 4 drinks per episode. Here at the Road Home program, about 20 to 25% of our first 100 veterans that we treated last year reported some degree of military sexual trauma. We are sort of preferentially getting these individuals because often for individuals who are suffering from military sexual trauma, simply walking onto a VA hospital campus can be activating because it reminds them of the military culture so much. And so we're relatively innocuously located on the Rush University Medical Center campus in a standard sort of medical office building. And so we don't, I think, reflect as much of that military feel when you walk into our building military care setting. So we feel like we have a lot of experience with MST. So again, in case 2, the key would be to screen. With MST, it's important to listen for somatic and traumatic symptoms. Military sexual trauma often involves a close psychosomatic or somatopsychic connection. Ask permission, again, to discuss alcohol or cannabis use. Try to address the underlying problem and discuss the potential reduce use. So a harm reduction approach is very much at the center, I think, of SBIRT philosophy. Acknowledge the dual role of substances. They do help and they can hurt. And one way to sort of frame things after asking permission is to ask what it would take to reduce your cannabis from 3 to 4 times per day to maybe 2 to 3 times. That sort of incremental approach can be really helpful. So these are some references now that we assembled, that we've drawn on in putting together some of the data that's in this presentation. We encourage you to look at them and to review this at your own time. There is substantial information both on the ATTC website, but also SAMHSA's SBIRT website that all of you should be aware of if you haven't explored. presentation back over to handle and address some questions, and I'm going to put our team on a speaker so that we can all collectively address them. Thank you for your attention.
Thank you. Thank you, Dr. Karnik, Dr. Frazee, and Mr. Turner. Thank you so much for sharing your expertise and about the Road Home program. We have several questions that have come in, and I'll just remind folks that you have a questions pane over to the typically found in the upper right-hand side of your screen. You can use the questions feature to type in your question, and I will take a look at some of the questions that have come in, and then it does not look like anyone has identified a particular presenter to answer the question. If I do see it come in and you have a specific question for a specific speaker, please note that in your question. Otherwise, I will just offer the question up to your team, Dr. Karnik, and you all can decide who might want to take on the question.
Sounds fine. We're all in the same room, so we're able to kind of move between us pretty easily now.
Terrific. And, one of our participants would like to know if anyone who's presented has been deployed, and if you have been deployed, are there any unique factors that people should be considering? They're listening to this today and thinking about, if you're working with folks who have been deployed, is there something different or unique factors involved that you should be considering versus someone who has not been deployed? They're veterans, but they have not been deployed over the last, I don't know, X number of years, as we've seen more and more people become deployed multiple times. Any thoughts or reactions to that?
Well, this is Tanya Frazee, and it's interesting because Nick and I were just sort of speaking to that. That's another subcategory. If you're working with people that have been deployed, typically, and especially the multiple deployments, it usually is different. People that are deployed tend to have triggers and issues and possibly, substance use that might be related to the environment that they were in. So again, this really relates to digging a little bit deeper in which theater, which basically means which era did you serve in. Or were you in the mountains? Were you in the jungle? Were you in an urban environment where, unfortunately, now a lot of our service members are dealing with running through the alleys in sort of a guerrilla warfare type of thing where you can't identify necessarily who the enemy is. All of those things come into play versus an individual that perhaps has a job where, like I do right now, sitting sort of behind a desk looking out a window. However, the other caveat I want to add briefly is it's very important to not discount an individual's experience, because I had mentioned earlier moral injury and some of those other possible considerations come into play because, as we all know as mental health professionals, a human being and a human mind can take something in its own individual way. So be cautious, or I would request that you be cautious not to discount the person that didn't go on multiple deployments, not to discount the individual that works behind the desk, and just to let every veteran and every service member sort of come to you with all of their pieces and parts and meet them where they are. I hope that's helpful.
If I can add something to Ms. Karnik, I think Tanya's making a really good point. Deployment is really a process, right, of people sort of disengaging from civilian society, being posted to a role, in some ways, and then, hopefully returning. And it can be a very stressful process. I think that's one thing to keep in mind. But Tanya's very right to point to the fact that individuals who don't deploy often have a high degree of guilt about the fact that, maybe their friend or their colleague who they have worked with side by side did deploy and they didn't. And so it's very important about how you tread and talk to them about that, because you don't want to inadvertently exacerbate that guilt by saying, oh, well, you didn't really go abroad, so you must have had an easier experience, right? It simply isn't the case. The stressors of sort of doing some of the roles that they may be doing, or in theaters nearby. I mean, the medical teams that serve in Germany right now see some of the most severe injuries coming out of the war theater that you can see. And yes, they aren't in a war situation directly. They're not frontline personnel, but they are caring for the veterans, or the active military individuals who are coming out of those spaces. And that can be as stressful in many ways, and can activate PTSD, can activate the substance use in very parallel ways. So, I think that's important to keep in mind. Tanya and I just returned actually from UCLA and also visiting the Coronado Naval Station in San Diego, and saw the SEALs training facility. San Diego is a beautiful place. It's a lovely location. The SEAL facility is located on Coronado Island, which itself is beautiful. But these young men are, and I think it sounds like in the near future, potentially women are going to be under a huge amount of stress. The training that they go through to become a Navy SEAL is really meant to test the limits of their endurance. And that can force people into this pathway of substance use very easily if they aren't coping, and if they just don't have the resources to get through that. The statistics we heard on the washout rate is just unbelievable, and the stress of going through that and maybe not making it into the SEALs, can lead to disappointment.
Thank you both for very thoughtful answers and raising some really important issues. I can see some folks have responded very positively and acknowledging what you're saying about whether they're on deployment or if not been on deployment. There are all these other factors that you have to really embrace where that person is and their experience in life, and not discount whether they have or have not been on deployment. And some folks are really very grateful for those comments, so thank you. There are a couple of questions that are somewhat similar, and a lot of interest in your program, in the Road Home program, in terms of how common is this program? Is this program very specific to hospitals that are connected to the military somehow? Is it a specific center within state? So are there more programs like this? How is this? Is it funded by the military? Are there other models like this out there that people can look to if they're thinking about, essentially pitching to their own environment that they'd like a program like this?
Sure. This is Niranjan Karnik. I'm happy to speak. So our program is actually a program-based program, which is part of Massachusetts General. That program was our chairman here, Mark Pollock, and has been in existence about, I want to say, 8 years. Don't quote me on that, something close to that. Mark, and with his colleagues at Mass General, sort of identified that there was not sufficient capacity to treat veterans, even within the current veterans, care system, and felt that, a public-private partnership of did. And so they actually got support from the Red Sox team in Major League Baseball in Boston. And also there was some initial support from the McCormick Foundation that helped them, build this center basically. And they, like us, use, privately raised money to fund the care at the center. And they don't, or their family members for care there. Introduced when they established the center to include families, fundamentally in the care planning. And other centers around the country. So Home Base is sort of our sister program. Emory is getting ready to open their new program in Atlanta. We have another sister program. Actually, there are two programs at UCLA. The Nathanson Family Resiliency Center, which is run by Dr. Patricia Lester, who, like me, is a child psychiatrist, and she's running an incredible project for the Defense Department called the Focus Project. You should check out their website if you're interested, project.org. And there's also another program, which is a surgical reconstruction program called Operation Mend at UCLA. And those programs are now sort of part of this network with us. University of Michigan has a program called MSPAN. And there's another program at NYU, which I'm blanking on the name of that program. But if you go to the School of Medicine there and Department of Psychiatry, I'm sure you can find it. Charlie Marmar runs that program. So there are more of these programs growing, and really it's coming out of a need for capacity. You know, the VA alone can't do it, I think, is you know, what we have learned over the past several years. And there are things and interventions that by statute the VA is not allowed to do. You know, fundamentally the VA can't treat families of veterans. It was never intended or designed for that. And I'm a great fan of the VA system. I spent, you know, a significant part of my training as a resident at the Palo Alto Veterans Administration Hospital in California, and felt that I learned a lot, felt that I really learned about veterans. That was part of the reason why I was recruited into this role here. But, you know, I think we need both as a solution. And I would encourage, you know, other programs, other universities that are interested, if they you know, want to talk to us, we're happy to talk to them. I'm sure if they, you know, touch base with any of the other partner sites I've mentioned, the leadership at those programs would be happy to talk to them as well.
Thank you very much. We have several folks on our webinar today who are with Wounded Warriors programs. SBIRT is new to them, and it's currently happening in their setting. And so I think this is really, really useful information as they are beginning to think about how do we study in the Wounded Warriors program.
And Tracy, I should say that we have just recently sort of, you know, signed this, you know, new agreement with the Wounded to you know, sort of expand and build this new national network. And one of the things that we're going to be doing here at the Road Home program is actually experimenting with using an electronic screening and brief intervention platform, which will be sitting sort of in our waiting room and that veterans can access as they, you know, come in and sit down. And so I'm optimistic that that's a platform that could be used in non-clinical settings and without having providers available necessarily, and that it would go through the screening and some of the basic brief almost in an automated fashion and sort of connect people appropriately based on their score to a teaching module and they're interested.
Mm-hmm. Well, that's an exciting new adventure and a way to scale up when, you know, there are limited resources and you want everyone and screening everyone, and using technology has shown to be a very useful methodology for doing that, and there is some evidence to support the use of what we call ESBI, electronic screening and brief intervention. And so it's really nice to hear that you're going to be doing that, and we'll learn from you over time about what your experience is, because I do think we're going to be seeing more and more of that. A couple of other questions have come in. One is about where you can find the audit and the DAST. We'll make those available to you. We'll post them to the website where all the PowerPoints will be housed, and we'll give you copies of available tools. So we'll make sure that you have those. But there's another question, audit and the DAST. Do you embed those into a broader screener that assesses for trauma? Different types of war-related trauma, could be interpersonal violence. Do you embed it within other tools, maybe depression, maybe there are other things as a standard behavioral health screen?
So here at the Road Home program, we do have it embedded. Actually, we have a very large and somewhat intimidating intake packet that we ask these veterans to complete. So it is part of that where we screen for trauma, we're screening for TBI, brain injury, military sexual trauma. And one of the things that we found is I think we're one of the few centers that actually put in those military sexual trauma questions. And so that's that we find coming into our center come from process with substance use. When you ask, you will discover that there's a lot of it going on. If you don't ask, you won't find out. We are moving very quickly now at Rush to actually have the audit and the DAST available within our electronic health record as part of an intake, and done in all of our ambulatory care, primary care clinics. So, we'll have those pre-screener questions that Nick outlined in the presentation, and then those will be linked to expanded question then batteries. It'll sort of open up another set of questions then for them to complete. So yes, we embed these, and we try to embed them into our routine.
Okay, that's great. I think people will feel comforted when you're thinking of things you ask patients and clients. Rated. It sounds like it's working well, and people are completing the screens. Are there any key barriers or key facilitators to screening in the brief intervention process unique about the strategy and working with veterans?
Well, I think the main thing that we find in terms of the obstacle to this, veterans or the active military, with some of the kind of key things that we did, if you approach in a respectful manner, they really are very willing to talk and to be open about their experiences. What we find is actually that most of the resistance seems to come from other providers when we try to introduce SBIRT into institutions who are not professionals or addictions professionals, feel very hesitant to ask these questions because they're afraid of getting a positive answer, afraid that it's going to demand of them action on their part. And I think it's, part of our sort of SBIRT training model is really to help empower clinicians outside of the mental health and substance use, treatment field, to feel capable, using an approach in their office. Comfortable with that.
Mm-hmm. Thank you. This next question is, so the experience that you've had in your program and even outside the program, the general medical work that you all do, have you seen how you working with military men versus women? Are there certain strategies or approaches? Has something been more effective with men or women? Something that should always be brought for women when you're having conversations? Is there something as a factor here?
I think it's a great question. I think on its surface, one of the things that sort of has gotten recent highlight is the rates of military sexual trauma, and our tendency would be, and certainly as a population, women are at far greater risk and have higher sexual trauma. But what I think to us, because we included these military sexual trauma questions in our routine packet, we have a lot who are reporting this, and 2/3 of the individuals with MST that we treat, and 1/3 are men, and oftentimes experiences that go back, and we see that the MST and substance linked in some way. But philosophy outside MST, I think that the cultural force and the military law that alcohol and substance similar ways to that which men do in the military. It is part of socialization to the military that cuts across both genders in a very. I think that those experiences are victimized, while substance certainly disproportionately fall onto women.
Mm-hmm. Thank you. Yeah, thank you for that. Question, I can't remember exactly the time. So they're asking about, I think presenters talking if someone has a mild alcohol use, and the question is better to handle patient, seeing them through physical extinction, naltrexone, and so this may have been about where they were in maybe they were at higher risk, developed that it takes another profession versus instead of just trying to right in the setting with pharmacotherapy. Can you comment on?
Sure. I think as a general rule, I would say that pharmacotherapy for substance use disorders is underutilized. But the things to realize is that this that we use doesn't work well. And SBIRT really asks of its providers, when we're doing our trainings, that you're going to be the one in your office. The person who's doing the screening is this part of the team that's going to do it. And I think that it isn't to discount biological approaches. Those certainly have a role in treatment. In terms of sort of effectiveness for amount of time, right? We think that the brief intervention should be a norm for all of these individuals who screen positive for some degree of substance use difficulties, because it's just there's not a lot of toxicity. You're not putting your patient at risk at all. Pharmacotherapies have to be weighed in the context of other medical issues and the general health of the person who's there in front of you. So we would like brief intervention to be sort of a level platform that everyone gets it and gets it in those settings where the screening is happening rather than it being a referral.
Mm-hmm. Okay. Well, thank you. Thank you. We do have another minute or two for questions. We'll be wrapping it up shortly, but I want to get one more question if we can. What might be an appropriate way to address and thus reduce the high rate of prescribing opiate-based medications to service members? Any thoughts on that?
Yeah, everybody in the room is kind of sighing here a little bit because we don't have a good answer for that. I mean, one of those things that we know from the experiences and what we hear, the injuries that that service members face, and certainly we don't want them to be in pain. I think the difficulty comes is that the military has excellent medical care globally in terms of the way in which it's structured, but the continuity of that care is difficult to maintain. So, the individual may get injured in a military theater and then get transferred to Langstein in Germany, and then after, recovery there for some, sent back to the U.S. And when you have that many multiple providers and handoffs happening, that's where we feel that to some extent the opiates can just be continued, and the individual service member will say that they need it to address their pain. But the overall strategy of that this is a temporary intervention isn't really being addressed. The Department of Defense right now is actually in the process of seeking researchers and investigators who can help them design a better handoff system, and I'm hoping that that's going to involve some type of opiates as one thread in that treatment sort of system that they want to design. And they very much want to use some type of electronic infrastructure to be a way of doing these handoffs. And I think if they're able to kind of pull this off, that may be a good model through which to monitor things like opiates and appropriately use them, and then for weaning them and getting individuals off of it. There's so many systems at play. That's the difficulty in this, and it gets exacerbated then when they're handing off from the DoD Medical Corps to the VA system. Again, another handoff and difficult to manage.
Well, thank you. And we only have one more question. We're actually getting to all of them. And so if someone wanted to refer a veteran to your program for treatment, how would they do that?
So they can go to our website, roadhomeprogram.org. We actually have a portal through which providers and patients can contact us. They can call our telephone number that's listed on the website. They will get in touch with one of our outreach team who will be happy to kind of get their information. Our program really does specialize in treating PTSD, mood and anxiety disorders. There are a number of veterans who suffer from sort of chronic psychiatric illnesses that we actually partner with our local VA in a very productive and often refer people to them. They tend to refer to us some of the more family-oriented cases at the range of our services here. But by all means, they can reach out to us. We have a presence on Facebook and on Twitter. If folks are interested in following our program, they can, I think it's @road_home_program is our Twitter handle. You can find that if you go to our webpage, you can connect to there as well.
Great, thank you. Well, thank you, Dr. Karnak, Dr. Paday, Mr. Turner, for your terrific presentation today. I just want to remind everyone that please complete the CE quiz to be able to earn your free CEs. Also, very, very important to us to be able to bring you this kind of quality education every month. It's extremely important that you complete a very brief survey evaluation form. Misty has already posted in the chat box a link to that. I cannot stress enough how grateful we would be for you completing that. You'll receive a follow-up email, and you also have a link to the survey and how you will be obtaining the CEs. And just to remind folks, please take advantage of all of the webinars in our series. I appreciate everyone coming and joining us today, and a big thank you to our presenters. We look forward to working and his team. Next month, we'll be offering another webinar with this terrific team. So please, if you like what you've been hearing, please join us again to hear more about addressing substance use in other special populations, LGBTQ. The SBIRT that will be July 22nd. So thank you, everyone, for appreciate all of many of you I see have been coming to many of our webinars. We really appreciate it, and it's really that you are enjoying the work that we're bringing you in your professional education. So thank you to you for joining, and to our partners, and thank you, presenters, and I hope you all have a terrific day.